back to this. What's going on here is that you have problematic aspects to the behavior that precede any desire or feeling of importance to change, and then you have to have kind of a desire for change or feeling that it's important to change to feel confident or capable of doing it, and then finally planning and doing it. Okay, so why do we have stages of change? There's a few reasons. One is you can focus on where they're stuck, okay, where their barriers are. It also gives you a sense that change is not easy and that it's a pretty arduous and long, involved process. So instead of thinking of it as like, oh, you just gotta quit. It's simple, which I'm sure most of you don't. It definitely reifies the concept that it's a big deal. It's a huge transformation that people are making when they're making these sorts of changes. And it's kind of nice to be able to use the stages of change in terms of feeling empathy, kind of feeling what they're feeling in their shoes. I want to define something for you. Change talk, okay? And it's a very simple way of looking at basically the patient's expression of their own desires, their ability, the reasons why they want to change, or the reasons why they feel they need to change. That's called change talk. And the whole idea with MI is that if you can elicit as much change talk as possible, you will eventually get more change from your client or patient, okay? And this is sincere change talk, not change talk that you're trying to put in their mouths, okay? You want it to really sincerely come from them. So, for example, I like partying, but sometimes the mornings are rough. So the fact that this person is saying that the mornings are rough, it's an expression of the problematic aspects of their of a particular behavior, and that's change talk. So sustained talk is the opposite. It's the patient's expression of their own desires and their reasons and their need to stay the same, and it includes the inability to change. For example, in this conversation, if at some point the client says, well, the mornings are not that bad, that's sustained talk. You know, talk that kind of talks about not changing. All right. Now, this is going to be a little bit of a complicated slide, but I'll try to get through it briefly, and hopefully it'll make sense. But the idea is, I don't know if people have seen this kind of diagram. The idea is that these are very, very general kind of tones that you might have, or processes that might be involved in having communication with a client or patient. So on the one hand, you could follow, which literally is that the patient is directing the whole conversation, you know, and you're not really putting in that much. Then there's directing, which is the opposite, and which is the most common kind of model that people conceive of when it comes to doctoring and being a physician. Okay, and guiding is something in the middle. It's like some combination of following and directing. So if we look at following, the things that we do in MI that are following are, we practice empathy, we accept the patient, we accept them unconditionally, okay? And this is sometimes a hard concept to grasp. It doesn't mean you don't disagree. It doesn't mean you can't disagree. You can be in disagreement, but you always accept, okay? Have that tone of acceptance. Rolling with resistance, we're going to talk about in one of the cases. It's very much like acceptance. So these are all the ways in which we kind of defer to the patient, we acknowledge the patient. Other terms that you're going to hear later is autonomy, respecting autonomy. That's kind of part of acceptance. So then the other side in terms of directing, so there is directing in MI, meaning that sometimes we give information. There's a big kind of imminent feeling that comes from providers to give information, especially when we're hearing sustained talk. And then the most important aspect of directing is eliciting and reinforcing change talk. That's the biggest thing, because as I mentioned, that leads to behavior change. Okay, and what I think of as the micro skills or tools that we use to do these both are what's called ORs. So open-ended questions, that's the O. A is affirmations, that's the A. Reflections are reflections, that's the biggest part of, that's the most important micro tool, micro skill. And then S stands for summaries. Okay. As I'd said, guiding is not the negation of this or this, it's the use of both of these in the right places. For example, if patients are resistant, you might need to do some following, accept them, roll with their resistance, be empathic. That helps them get on board so that once you have a good, trusting, empathic relationship, you can be more selectively directive by giving some information and most importantly, eliciting change talk. Okay, I just want to show this to you because this is another another concept that's evolved over the last few years and is in the latest edition of the MI textbook from Miller and Rolnick, and that's the 4 processes. And they are engaging, that's the first step. You have to have this before you can focus. You have to have the client engaged before focusing on something in particular. And then you can invoke change talk and eventually planning. So engaging and focusing are very necessary for MI, but just doing these is not necessarily MI by itself. Engaging and focusing is also part of taking a history, right? So it's not necessarily defined as MI with these, but you need these both to have MI. Now, evoking and planning are very specific to motivational interviewing, especially since we're talking about evoking change talk. All right, enough talk. Let me get my bearings here, 12:21. Okay, you are seeing a young man. We're gonna do this case, and we're gonna see how you guys wanna respond, and we'll go through the different steps and learn a little bit about some MI skills. You are seeing a young man in your clinic. He tested positive for HIV a few months ago, and an antiretroviral treatment regimen was initiated. He is sexually active with numerous male partners, occasionally using condoms. He scores a 2 on the CAGE screen, prompting concerns of alcohol abuse. You want to explore his drinking further. Okay. I'm assuming people know what the CAGE screen is. It's a very handy-dandy screen that primary care providers use a lot, as well as mental health providers. So a 2, which is out of 4, is considered something that should be explored further. So that's what you want to do. So how do you do that? All right, so I'm going to just ask, what's the very first step? And so if you want to, I'm looking at the group chat. If somebody wants to send anything by group chat, we can discuss it. And if not, we'll just move on. The first thing actually is a very simple thing, is asking for permission. Asking for permission from the patient. You don't have to ask for permission every single step of the way, but it is a very good, important practice to do because it emphasizes that this is collaboration, okay? It kind of de-emphasizes your position as an expert. Would it be okay if we talk a little bit about drinking? I noticed you answered these questions in these ways. And so to explore it, you ask open-ended questions. Now, open-ended questions are hopefully something all of you understand and know about. Questions that cannot be answered with one word. It's not a yes or a no. It's not a number. It kind of forces and encourages the patient to really be more forthcoming with information. That's an open-ended question. So,
Pran?
Yes.
In the chat box, someone noted that maybe exploring his history, is that something that you would explore?
Oh, yes, yeah, I just saw that. Sorry. Thanks for pointing that out. Yeah, absolutely. You can explore the history of, when did they, or actually what I like to do is, I like to start with, tell me a little bit about now and drinking. Tell me about What are the situations that you drink in? And tell me what it was like when you were younger, and tell me what it was like when you first started in X, Y, and Z context, like going out with friends to the bar or drinking in college or high school or whatever. So absolutely, you got to explore that history. So let's say you get more history. Okay. So this patient is 26 years old. He's been feeling very stressed recently, especially with the recent HIV diagnosis. He has been drinking since he was a teenager and states that it relaxes him. He does think that drinking is related to his inconsistent condom use. He concedes that quitting would be important in helping him achieve viral suppression, as well as doing better with condoms to prevent STIs. When asked about quitting, he frowns and says he has tried to quit several times in the past without success. Okay, so what do we do first? We try to assess what stage they're at. So I told you that the stages of change and MI are different, but they work very collaboratively together. I use the stages of change, as I said, as a way to practice empathy. So let's start with that. Where is this patient? From the history that you got, where is this patient, let's say, stuck? And if you remember from my previous slide, it's a problem. It's I see contemplation. I see a couple of you said contemplation, which is great. Let's go to the second slide that I showed, which is identifying a problematic aspect to the behavior, identifying that they have a desire or need for change, or thinking that it's important, and then feeling confident or capable of change, and then finally doing it. Those are like the different ways you can contemplate. So which one of those ways is this patient at? Okay, you can ask the question of why has he tried to quit last time, but what does that tell you, the fact that he tried to quit last time? Why is he frowning when you ask about quitting? So the point is, what I'm trying to say is, he's stuck at feeling confidence or capability. So he sees it as a problem. He talks about how it's a problem. He talks about how he'd like to be better with drinking, so that, and drink less, so that he can have better behaviors, sexual behaviors. And yet he's tried many times and he feels discouraged, because that is an issue with confidence. So I'm seeing in the chat box that he may see it as a problem. Yes, I would say would you say he kind of knows that it's already a problem, right? He kind of says that there. And because he does know how, but it's a problem. Okay, he doesn't know how, exactly. Or maybe he knows how, but he just needs to boost himself to try again. Okay, so now let me actually do this. So then, how would you approach this patient at this moment, given these, given where he's at, and given what we just talked about? So, what happens when he tries to stop? You could certainly ask that. You could ask a question. That's a way of, in a way, that's kind of like saying, well, what are the hurdles to trying again? What makes him relapse? Same thing. What, that's in some ways like, what are the hurdles to quitting? Be careful with that, because what are you eliciting? What kind of talk are you eliciting? Is that change talk or sustained talk? So that's sustained talk, right? What happens when you try to stop, and what makes you relapse, and him talking about the difficulties of it is sustained talk. So now this is the nuance of MI. Sometimes you have to talk about sustained talk. You can't completely ignore sustained talk. So you have to kind of, accept sustained talk, kind of empathize with it, and then you can move on to change it. Before we do any of this, what would be the very next step that you would do? What does quitting look like for him? Okay, kind of exploring what would be ideal, maybe. And in some ways, that's eliciting change talk, right? Before you ask a question, what would be the next thing you do? Affirm him trying to stop. Absolutely, that's a great one. Just looking at his strengths. Absolutely, so that's a good one. fact, let me just go ahead and move to the next slide. And so this is kind of like my suggested MI approach. So the clue here is affirming, because all the other responses are questions. They're all great questions. The key is, before you ask a question, just reflect, okay? And affirmation is a kind of reflection in some ways. So you always start with your patient's view and perspective. Get into the habit of giving a reflection, okay? So here's a reflection. Drinking is a way to help you relax, and you've been struggling with a stressful situation. At the same time, you're concerned with the negative effects it is having on your health, okay? So try to hold yourself from asking a question right away and get into the habit of reflecting back what you've heard in an empathic, non-judgmental way. All right. And I think the person who mentioned the affirmation, I think that is a great idea too. You can follow it up with an affirmation. You know, when it comes to your goals about drinking, you're determined not to give up. Okay. The idea is that you show the client that you're listening. Being listened to is powerful in and of itself. Okay, in terms of relationship building, in terms of information gathering, he's much more willing to disclose issues that he may be afraid to when there's a trusting relationship. So that's a very important piece. So try to get into the habit of doing that. Let's see. Here, so we talked about, I see that someone mentioned pros and cons and decisional balance. That's a great strategy. There are some issues with decisional balance, that some traps that you can get into, with it, and we can discuss that later. But many of the questions that I see in the chat box are great. Here's another thing. I'm going to bring up the use of scales. This is a very common tool that's used in MI. And if anything, it kind of shows you how to even ask about change talk in a way without the scales. But when you learn the scales, you kind of get an idea of how to ask questions in general about eliciting change talk. So I see that Dottie wrote, on a scale of 1 to 10, absolutely. On a scale of 1 to 10, how important do you think it is for you to quit drinking? Let's say the patient says 9 out of 10. Okay. On a scale of 1 to 10, how confident are you that you can quit drinking? Patient says 4 out of 10. All right. So what do you do now? What would you say in response? What would bring you to a 5? On a scale of 1 to 10, the patient says 4. What would bring you to a 5? Listen to how you're asking that question. What would bring you to a 5? Okay, it kind of evokes imagination. Like, imagine that you are more confident. What would it take to get to that point? So that's a brilliant question. Look at the way I'm wording this question. Okay, very, very similar question, but with a different tense. Why is it a 4 and not a 5? Why is it a 4 and not a 6? What kind of talk would be evoked there? What kind of talk would be evoked if I asked the question that way? Why is it a 4 and not a 5? Would you be getting change talk? Maybe there's a delay with the chat, but I'm sure. There we go. Sustained. Excellent. So I got a number of responses. It's sustained talk. It's interesting because it's the tense that changes, right? So ask it in a future tense way. How, what would take you up there? What can I help you with to take you up there? What would the situation be like so that that number would be higher? What's another question you could ask? There's one other question that you can ask from this scale. Why not a 3? Exactly. Because you can see that if you say, why is it a 4 and not a 5 or 6, you're going to get sustained talk. So if you just reverse it, why is it a 4 and not a 3? You're actually kind of evoking their strengths, their capabilities. It's not a 3 or a 2 or a 1 because, it could be, for example, they did it before. They were able to successfully. Again, focusing on the success as opposed to the failure of relapse which in fact is just a trial run, as I had mentioned before, right? So great. This is great. So same questions that I was asking, and actually as you saw on the next slide, I might as well just give it to you. I was going to have you come up with the summary, but it's probably too much to type. But we often end with a summary. There's a few points to the summary that are helpful, which is just making sure you got the story right, have them correct you, having them listen to the summary, especially because you want to kind of create it in a way that's positive and affirming and ultimately can help you elicit change talk. So I wrote, let me see if I get this straight. You want to cut down or even quit drinking. You have done so successfully in the past, but you've also been discouraged at the times you have started drinking again. Yet I see how determined you are to not stop trying. Where does this leave you? Where do you think you'll go from here? Okay, so again, you can see that there's less judgment in here. If you could easily say, it looks like you want to quit drinking, but you keep failing, et cetera, et cetera, et cetera. Not the kind of language you want to use. So, all right, let's go to so this is the same case, but forget about this being the 26-year-old man who was at that stage of not having confidence or capability. Okay, so we get this. The patient is actually 35 years old. He drinks with his buddies, who he hangs out with at the local bar. He feels a sense of community with them, and drinking is a shared pastime they enjoy. He does not think drinking is related to any health problems that he's had. Instead, he blames the side effects of the medications for his health woes: headache, nausea, stomach aches, and fatigue. When asked about quitting, he says, well, if anything, maybe it'll put less stress on my wallet. And let me just add that he does not think that drinking is related to his inconsistent condom use. Okay? So, what do? The first step is, where's his stage? Where is he at? So where do you think he is? And remember, is it a problem for him? Is it important for him? Does he feel confidence? Okay, again, everyone's saying pre-contemplation. Is there any contemplation here? Is there any signs of contemplation here? Contemplating the money savings, exactly. I love it. You put it, CL 1118 put contemplation, and then in quotes, contemplating the money savings. And if we were in person, I would love to have a richer discussion about that, but we can do that on February 7th, hopefully. Yeah, that's what's important to him, the money. And in MI, we're like, okay, let's not look at what we think is the right perspective to look at, or the more important aspects of this situation. Let's take it from where they think it's important. Money's important to him. I mean, money's important, right? So using that, as Daria said, we can use that to bring about more discussion. Absolutely. So that's where we would start. Okay. So he's contemplating. We're not sure how important it is to him. It doesn't sound like it's very important or problematic, right? Okay. So how would you approach this patient at this moment? So here's an MI approach. Again, it's starting with the patient, reflecting, okay? And especially in this kind of situation, it can be difficult because it can be easy to jump to trying to fix him, trying to correct him, trying to align his perspective with ours. And you really got to hold off on that. That's something if any of you have done any reading on motivational interviewing, there's something that's called the writing reflex. You want to make it right, and it comes from a good place. You want to help, but it's actually ultimately works against you and against the patient. So take a step back before you want to fix it. Just reflect where this person's at, and actually, from a spirit of not judging the fact that he has a different perspective, that it's about money and not his health or his sexual activities and his behavior with condoms. Okay, so it seems that drinking is an important social activity for you, but you also would like to quit because it would be better for your finances. That's kind of like a straightforward reflection, just kind of acknowledging what you've heard. Now, here's a roll with resistance statement, and I'm curious what people think here. Yes, it does seem that the side effects of the medications are pretty bad. Again, if live, we can, my experience is that we've had a lot of discussion about this. It can be a difficult thing to say. Maybe a better way to word it, and I actually feel like there might be a maybe a better way to word it, which is, yes, to you, it seems like the side effects of the medications are pretty bad. Okay. Because that's what I mean when I say it does seem that the side effects of the medications are pretty bad. You don't want to agree with the patient necessarily, because you may not really agree. But you want to acknowledge where they're coming from. So you can add here, yes, so it seems from your perspective, it does seem that the side effects of the medications are pretty bad. The key is you say it in an accepting voice. That's the most important key aspect to this. And that's what's rolling with resistance, as opposed to fighting it and trying to fix it. You can use the scales, all right? How important do you think quitting drinking is for you? Let's say the patient says 3 out of 10, okay? How much of a problem is drinking for you? And the patient says 4 out of 10. Now, notice I didn't look at confidence, I looked at problem. Because remember, problematic, important, and then confidence, right? So I went in the reverse direction, because how important do you think quitting drinking is for you? It's pretty low. So instead of asking about confidence, I want to know, well, is it important to you to some degree? If you feel like it's important a little bit, maybe it is a problem. Let me gauge that. I just want to ask about the comment from Dottie, which says you can also use a miracle question. How would you ask that?
So can you hear me?
Yes.
Okay.
I can hear you.
So basically, like, if you can wake up today and all of your problems will be solved, what would life look like for you?
Good. Perfect.
I would also maybe like to ask some questions about some of the people that that he loves and that's in his circle. What are they saying about his drinking?
Yes. No, absolutely. Yeah. So basically what I've done here is, we talk about a reflection, and then moving to the scales, what I'm doing is I'm now eliciting change talk. So there's reflection, following, empathy, followed by, let's see if there's any change talk. So that miracle question is great. I asked you to state it out because it depends on what the goal is, right? So if all your problems went away, what would life look like? That's a great way to do it, and see if there's any concern about drinking on his part that you might uncover. Like, well, I wouldn't be drinking as much, or something like that. So, I mean, he could easily say, well, I just wish I had more money, so I wouldn't have to worry about the money when it comes to drinking. So you never know. You have to try. So what about confidence? What do you think about asking about confidence? What do you guys think? Do you think that's a question that should be asked? Do you think it'll be helpful? Yes. Okay. So Dottie, you say yes. You wanna unmute and
Yes.
discuss your.
I really love motivational interviewing, so I'm sorry about that. But
No, don't be sorry. I like that.
I would definitely ask about his confidence, because that can be a barrier to him trying to stop or trying it on for size. So if he's not confident, then sometimes we're not likely to do things when we're not confident, because we don't want to fail, right? So I think just trying to figure out where he is with his confidence, and then also asking that scaling question again. If you're at a 4, what would bring you to a 5?
Absolutely. Yeah. Good. No, that's excellent. And so I ask about this because on the surface, it might not seem like it's worthwhile to ask about confidence. He doesn't think it's a that much of a problem. He doesn't think it's that important. You know, he could just say 10 out of 10 for confidence. And actually, that is sometimes what happens. But what you're getting to is something even maybe a little bit more subtle, which is that sometimes if we've felt failure, you know, you've had multiple relapses, if you felt that feeling of failure, you might your feelings might reorient your cognition to think that it's not that important, you know, and it's a way of protecting yourself. So you really got to a wonderful point here, which is that sometimes you have to. There's some secrets that are unlocked that you need to unlock, and this is one way to unlock that. But on the surface, he could be like, "Yeah, I can do it. I don't care. You know, it doesn't really matter to me." But if you dive a little deeper, you can get some really important information. Giving information. So we talked about, we reflect, we follow, we try to elicit change talk, okay? And then there's giving information. Sometimes we might feel the urge to give information. Now, yes, that's part of our writing reflex, but you can give information. There's a way to do it in MI, and as long as we follow those principles, we can continue the same spirit of acceptance and collaboration. So asking for permission before giving information. Like, for example, in this conversation, you might have started with asking for permission for just talking about drinking. And then now at this point, you feel like you can give some guidance or you can give some information to see if that will help them. You ask for permission. Would you mind if I tell you about my perspective? Would you mind if I give you some of my thoughts or some resources that I have? If you don't mind taking a look at them. Would it be okay if I shared some information about the medications you're taking? Okay. And then the second principle is you give a small, digestible, relevant amount of information. Do not barrage your clients or patients with, huge chunks. You will lose them. And this actually doesn't even have to do with literacy. I could say from personal experience that when I get a huge lecture of information from my providers, I remember only the last thing, the last couple of statements. So it's better to give small chunks. So give a small chunk. You are right about some of the medications you are on and their side effects. Unfortunately, we also see that when people drink alcohol with them to this extent, the side effects are much worse. Okay? That's one chunk of information. Then you ask for their feedback. Okay? So you want to know, well, what does this information mean to you? What do you think of this? Okay? What do you think of that? And sometimes you may not be, it's actually good not to ask for permission all the time. It can be a little too artificial. But asking for feedback is probably going to be more frequent in your conversations. Give a little bit of information, ask for feedback. There's another way to kind of look at this. It's called the EPE format, which is asking for permission. So it's elicit permission, provide, P for provide, a small amount of information, and then elicit feedback. Okay, and you kind of go in kind of like cycles of that, except for the permission. Then it becomes feedback, another bit of information, feedback, another bit of information, feedback, like that. Okay. So here's a summary. Again, if this was, and we'll do this. Those of you who will show up on February 7th, we're going to do exercises where you'll have to construct summaries with cases. Okay. Drinking with your friends has long been an important part of your life and happiness. It would be difficult to throw that away. And at the same time, you see that there are ways in which drinking has been not so good in your life, especially when it comes to money. Okay. And actually, I want to just, and then you can also provide some of this information in the summary if they reacted favorably to that. Okay, so you could add that to the summary. In addition, it sounds like you're thinking a little bit more about how alcohol is negatively affecting some symptoms that you have. And so you're willing to think about it. Hopefully they've gotten to the point where they're thinking about it. And again, you could end with, well, where does this leave you? Where does this take you? All right. Let's see how much time I got here. 12:48. Okay, we have enough time to do the next case, and then I'll stop, and if there's any comments or questions, if that's okay. All right, so this one is going to be different. You're seeing a 19-year-old woman for an annual checkup, and this obviously is going to be on mental health issues and screening for depression. I always use a PHQ-9. I use it for all of my, like I said, I'm a pediatrician. I use it for all my teenagers. So she got a score of 13, which technically leads you to a diagnosis or a suggestion of the diagnosis of moderate depression. Okay. So in reviewing the questionnaire with her, she states that she does indeed think she is depressed. When you suggest a referral for mental health services, she declines politely. When asked why, she states that she has too much going on in her life. Okay, there's just too much going on. I don't have time for that right now. Okay, despite the fact that they are, they acknowledge that they're having some issues. All right, so now, once again, where is this patient? Where do you think she is in terms of stage? Does she think it's a problem? Does she think it's important to make a change? Does she feel confident or capable? Any thoughts? Contemplation. Yeah. It's definitely contemplation. Where is she stuck there? Again, remember, contemplation is divided into how problematic a behavior is, how important it is to change, and how confident they are in making the change. She's overwhelmed, right? So what does that tell you? And think about the PHQ-9 if you've done it. They literally will point to, there's boxes and questions there that says, how difficult has this been in your life? Have these issues been in your life? Right? So that kind of tells you that to some degree, it's important to her. It's just not the most top thing. She's got other things and she's overwhelmed. And so she's not really capable. So that's the way I would look at it. It's somewhere in there. Human behavior and human cognition is infinitely complex. So we can't always, pigeonhole where she is exactly, but it's somewhere in that area. Okay, so how would you approach this patient? What would you do? That would be the first thing. Remember, before trying to fix anything, you reflect. Okay, so reflection, as I mentioned, and that can include rolling with resistance and being accepting of the patient. So, okay, it's not a high priority for you right now. Okay, you may think, well, you really need to get some treatment now because otherwise everything is going to get worse. But that's not where she's at. So you acknowledge where she is. Okay. And here's where I was mentioning before that you might have to kind of explore some of the sustained talk briefly in a non-judgmental way. So, for example, I'm curious to know what challenges you are facing at this time. You could ask, tell me more about your urgent priorities. Since I mentioned priority, you can talk about a priority list. And I think in MI, there's always this sense of, that's why we have scales, is this linear kind of sense of what's more important than the other. So tell me what else is on your plate. There's a lot on your shoulders right now. And then we can elicit change talk. And the reason why we kind of explore some of the sustained talk is you do want to acknowledge the hurdles. You have to acknowledge the hurdles. You can't really just elicit change talk without acknowledging the hurdles. And that's kind of part of that whole directing versus guiding versus following concept, is that you got to do a little bit of both. Okay. So in what ways have your feelings made it difficult for you to live your life? Okay, so, and you're pointing to, and I would directly point to the PHQ-9, to some of the answers that she has on there. Okay, so that's one. In what ways have your feelings made it difficult for you to face the challenges that you have? What would it take to move seeking help for your depression higher on the priority list? So this is, again, that way of kind of saying, well, if it's a 4, what would take it to be a 3 or a 2 on your priority list, right? It's the same kind of concept. You can also talk about how it's more important than other non-urgent priorities. So these are all different ways that you can do that. Then, let's say, despite the best of your MI skills and styled efforts, she persists in declining any referral to mental health services. Okay? What would you do? Let's say I do this with her, and she says, well, thank you, Dr. Saha, but I really don't want to seek any services at all at this point. I just can't. How would you respond? Any takers? Think about, leave the lines of communication open. Ding, good. And how would you say that? Is there a way that you might say that? You can unmute yourself.
I would say, okay, I hear what you're saying. We can talk about this. We can explore this further. And if anything changes, I'm here. But I would definitely try to encourage her to seek to take the referral. And like you said, if you've done it in your best efforts, we have to also believe in clients' autonomy.
Exactly. That's it. Exactly. And this is where a lot of providers get stuck. They just kind of feel like, oh my God, we can't let her leave without getting that referral and making that appointment. And, we got to do something. And that is the writing reflex coming back to, bite you in the back. So at the end of the day, and that's of course kind of a way I start statements supporting autonomy. At the end of the day, it's up to you what you think is right for you. Here, my perspective, as I've shared with you, is that it might be beneficial for you, but at the end of this day, you decide what's best. And yes, if anything changes, feel free to call me. How about if we check in with each other at a follow-up visit in a couple of months or whatever time you think is appropriate to just follow up this, So exactly. I think I said something very similar, right? It sounds like you have a lot on your plate right now, and while it would be very difficult for you to take the time to see a therapist, you do see how depression is affecting you in several not so good ways. Can we check in about this at the next follow-up appointment? In the meantime, let me know if you change your mind. And I see here, Karen says, need to wrap up. Were you going to circle back to decisional balance, or we'll talk about that in February? I took that, Karen, out because we changed the second case. So I can bring it up next time. And we can talk about, the nuances of it and where you can get into traps with it and how to use it properly for MI. So
that sounds great. Thank you.
Okay. So we have just a couple of minutes. Just curious to hear any comments or questions about this. If there's any out there. It's hard to encompass everything in 1 hour. This is like dipping your toes in it. But I hope it was helpful. Thank you, Dottie. All right. I think we're getting to the end. All right. Great. So as Greg stated, type your name and agency into the chat box if you haven't already. And this is very important. I'm glad you mentioned that, Karen. If there's any specific scenarios you'd like to work on in person in February, please let me know. Let your coach know, and they can let Karen know, whatever. But that's very important. I actually got some help from someone else at Columbia with the second case, with the first case rather, because I'm a general pediatrician. So, I want to know what really works for you guys, where you guys are really stuck. Okay. So, if you could send some specific cases, let's say you have a difficult case during the day, in your day, just note it to yourself and then kind of shoot an email, and hopefully it'll get to me, and then I can stylize a case around it that we can all work together on. Okay.
Very exciting.
Thank you. Thank you.
Thank you so much, Pran, for the presentation. We have, our usual evaluation form that we'd like everyone to complete, if you wouldn't mind, just so that we can try to keep improving. Greg put the link in the chat box. You can click right into that, and it'll take you right to the form. Dr. Saha, did you want to show everyone your email address? I think you have that in a slide toward the end, just in the event people have follow-up questions, but you can also get this information from your coaches or write to me directly. This is Karen. I'll put my email in the chat box. Anything before we close?
No, I think that's it. My email is there on the screen. So feel free to reach out to me directly with anything. I love talking about this. So thank you, everybody. All the best.
Right, members of my cohort, I expect that some of you will have some scenarios that you'd like to talk about in February. So if you want to chat with me at all, definitely give me a holler and we'll chat about it, okay?
Awesome, Michael.
Thanks, guys.
Thank you. Thank you. All the best. All right. All right, Karen, should I go ahead and stop?